Thank you so much. I am so proud to be joined here today with Dr. Oxiris Barbot, Adjunct Assistant Professor at Columbia Mailman School of Public Health and Senior Fellow for Public Health and Social Justice at the JPB Foundation, as well as Dr. Helene Gayle, President and CEO of the Chicago Community Trust and a member of the National Academy of Sciences Committee, leading the framework for equitable allocation of vaccines for the novel coronavirus. Yeah. Our session's going to be about 30 minutes. And so we're just going to walk everyone through kind of some of the bigger challenges we're facing related to race and equity as it relates to the COVID-19. So again, thank you both so much for taking the time to join us. I'll start off with kind of a softball question for you both. Coronavirus has changed how we think about life as we know it, right? With economic uncertainty, with race, with our healthcare system, the stay-at-home orders, school closures, businesses, I could go on and on and on. What's been the most surprising thing for you as you think about how coronavirus has impacted people of color and other vulnerable populations?
Well, I guess what I think is the most surprising is that people were surprised that this would disproportionately impact communities of color. We know that this is the realities. We know that something that impacted people who did not have the luxury of staying at home, that were already economically vulnerable going into this situation. We know that the preconditions that exist in many of our communities, other comorbid illnesses that are disproportionately impacting communities of color that make COVID more severe. I don't think we should have been surprised that this was going to have its greatest impact on communities of color. And the fact that people are surprised was a surprise.
Dr. Barbot?
Yeah. And I'll build on what Helene said, because I completely agree with her that it was surprising that people were surprised. I think the other thing that I would add is what's really been surprising is the degree to which we as a country have been flat-footed in our response, and that our systems of care haven't been able to ramp up and direct resources to those communities most in need with the speed with which we thought that they should have been there. And, I think a lot of it has to do with the fact that we have systems that don't talk to one another. We have data voids that keep us from being as nimble as we should be. But I think, in spite of that all, given the resources that we have at our disposal, I have to admit, that as someone who was on the front lines, I really was surprised at the way in which it was harder than it needed to be.
No, that makes sense. That makes sense. When you're thinking about, we're almost a year into the pandemic, which is very much so surprising for a lot of people because it feels like it's been so much longer, but we're only about entering into almost a year in March. What's keeping you up at night right now? What's really like keeping you up at night and worrying you as you think about where we are right now and where we're gonna be once we hit that official 1 year mark?
So from my perspective, what keeps me up at night is the long-term consequences of COVID. Not so much the long-term clinical consequences, even though we are learning every day more and more about, what happens to the body, if you will, months and years after COVID. But what really keeps me up at night is how is this sort of whole life shock going to be absorbed by communities that have little reserve already? And specifically from the mental health perspective, I'm concerned that as a country, we don't have robust systems of public health to help people with mental health crises. And so, it keeps me up at night thinking about how our children will be able to absorb and move forward in ways that promote wellness and health, and not in ways that really internalize or otherwise absorb negatively the traumatic impact of this worldwide pandemic.
Yeah, and I would just add to that, you mentioned the children, for instance. One of my big concerns is that we have had children out of school, and in situations, particularly for children in low-resourced areas that may not have had access to broadband initially when school went to distance learning. There's going to be a big learning gap, and it's going to further exacerbate the issues that young people who live in poverty, low-resourced communities of color, et cetera. I think there's going to be a real continuing gap in terms of the futures of those children as a result of the learning gap that has definitely occurred. I think the other thing, the long-term economic consequences for communities that have been so hard hit and that went into this already financially unstable communities where there's been huge disinvestment. So I really do worry about the long-term economic consequences and all that means for communities that were already hard hit and feeling the wealth gap that we have in this country, and it's only been exacerbated by the economic impact of COVID.
Got it. Dr. Gayle, I'm wondering if you can just kind of walk us through the scene in Chicago. I think a lot of people have heard about systemic racism during COVID. They've heard a lot about people of color being impacted. And for some people, that truly does go over their head a bit because they just are not used to having that conversation about the intersection of health and race. So describe the scene of how you see systemic racism kind of playing out in real time as the pandemic has gone on.
Well, it's been fairly stark. And again, the neighborhoods and communities and families that went into this already economically fragile were even more hard hit. And so we have seen increases in food insecurity and hunger. We have seen more homelessness. It's single digit degrees here and going down to minus if you include wind chill. And we see people on the street, sleeping on the streets. People have not been able to pay their rent. And so, we're seeing real day-to-day hard realities of people's lives hit at just the worst time. And we know that this is going to only increase. And as you mentioned, there's a huge interrelationship between economics and health. So, we know that the social determinants of health, access to income, access to nutritious food, public safety in your neighborhoods, all of these things, the access to education, transportation, all of these things have a huge impact on health. And in fact, account for more of the health disparities that we see in our nation than access to health care itself. We know that access to health care is critical. It's necessary, but not sufficient. People need the other aspects of things in their lives to be able to stay healthy and to thrive. So we know that this intertwine of health and economics is real, and we're going to see more health consequences, long-term health consequences, as well as long-term economic consequences as a result of this pandemic.
Got it. Dr. Barbot, you gave an interview at one point where you talked about, in GW Magazine, had talked about the idea that COVID-19 has ripped the scab off of inequities in this country. Again, we're almost a year into the pandemic. So how should the U.S. healthcare system consider those inequities as they care for vulnerable populations?
So I want to build on what Helene talked about in terms of the social determinants of health and your question about the scabs that we have in our country. I think one of the things that COVID has done is really made the point that when we talk about the impact of the social determinants of health, it's not an abstract concept. It's something that is playing out in a life and death scenario for communities across our country, and especially Black and Brown communities. And when we talk about, how to respond to these, I think it's also important for us to highlight the point that this is not just about the healthcare delivery system. In fact, 80% of our health outcomes are due to things related to housing, economics, transportation, education, et cetera, and really only 20% is due to healthcare access. Obviously, healthcare access is really critical, and certainly during COVID, it has also demonstrated the degree to which these inequities get amplified during emergencies. The fact that, Black and Brown communities, especially in the very beginning, weren't getting access to the testing that they should have had, that they were having challenges in accessing healthcare deliveries. And the fact that those inequities, I think what's really most frustrating is that a year later, those inequities are still playing out in terms of access to vaccination. So when we talk about what the healthcare delivery system needs to do, I think there's lots that needs to be done, but starting with collecting data and indicating race and ethnicity, starting with being intentional about how resources are directed to those most affected, I think are two very fundamental steps that will take us a long way.
Right. I think a lot of folks have also heard about the vaccine rollout, but specifically the data around testing, the data around vaccine and who's getting it, who's not getting it, data from nursing homes. Data has been so central and so key. How do you see the public health community balancing using that data for their own internal purposes so they can do outreach, while also kind of sharing that data so that the communities who are most impacted understand why this data matters and how they're impacted? And Dr. Gayle, we'll start with you.
Yeah, no, I'm just going to say, I think you made, in some ways, your question made the point. Clearly, data is critical. And, it's not enough for those of us who are, health officials or working on these issues to have the data, but it's important that communities have it so that there's a real good feedback loop. So, for instance, here in Chicago, so far about just under 50% of vaccinations have gone to white population, about 19% for African American, 19% for Latinx. But, if you put together the Black and Latinx population, make up about 70 to 75% of the infection. So clearly, there is a mismatch between who's bearing the brunt of this pandemic and who's getting access to what can be a life-saving solution through vaccines. So communities knowing this, I think, helps to empower them, helps to understand, where the need is greatest. And so I think data has to be our guide. Otherwise, we're flying blind when we take on these major initiatives.
Dr. Barbot?
Yeah, I think it's important to note that the data that public health has comes from the healthcare delivery system, and it comes from partners that we use to do the testing, do the vaccination. So one of the things that we really saw early on during the response last year was that hospitals were not reporting race and ethnicity consistently. Laboratories that were running the tests were not reporting these data consistently. And so we, as the public health authority, had to really push them on increasing the quality of that data. The other thing that I will say is that from the public health point of view, I think it was an opportunity or a challenge for us to really say, historically, we've worked on the premise that data needs to be perfect in order to release it. And one of the strategic decisions that we made in New York City was to act on incomplete data, because the trends that we were seeing were so concerning that I think it would have amounted to malpractice if we hadn't released those data, even though they were incomplete. And so I think as we move forward, it's the importance of prioritizing the collection of race and ethnicity in all healthcare delivery data, but also partnering with community to reality check that data and say, we think this is what the data is telling us. You as members of the community agree, are there data voids that we're not capturing? Because too often we focus on the data, but we don't realize that because of structural racism, because of the disinvestment in providers, for example, that may be serving under-resourced communities, they may not have the infrastructure to report on the data that we're using to make decisions. So it's as much looking at the data as it is looking at, are there data voids that are giving us blind spots, that we're missing significant parts of the community that need our resources the most.
And I would just add to that too, I think the importance of having community engaged with data can't be underestimated, because so often we collect data from community and never feed back. And so it's extractive, and people then feel used and they don't feel like they have ownership of the data. And so, data can be stigmatizing if used the wrong way. It can be mystifying. It can, there's a lot of ways in which data can be a negative. But I think when you develop a partnership with communities, so they feel like the data, they're part of the data experience, I think it makes a big difference, and it makes it less of an extractive, exploitive, way of behaving with communities. And I would just go back to my years on working on HIV and AIDS, where initially the way the picture was painted, it was very stigmatizing to communities of color to be pointed out as AIDS vectors and the people who were causing the problem, et cetera. But as we developed partnerships with community, there was a vested interest in having that data, because it really then could actually be very empowering when the community was at the center of it.
Right, got it. A question I'll pose to you both, as a journalist, I'm seeing it play out in real time with other newsrooms trying to tell these stories, with the idea that there are some state governments that are struggling to collect this data around vaccine distribution, and even hospitals collecting data on testing and whatnot. So from your vantage point, can you just kind of give a top line sense on why, collecting data around race and ethnicity is a challenge for some of these agencies to do?
Well, I think part of it is making it easy for people to fill out the information, and having better systems, and have it be a priority. I went in yesterday for my second dose of my COVID vaccine, filled out a form, very simple. I saw people, health staff, when people left out something on the form, they said, your form is incomplete. Could you fill out, X, Y, or Z question? It's not that difficult, but people have to make it a priority. You have to have people there who are looking at forms and saying that they're incomplete, working to make sure that we get the data, but you have to believe that it's important.
Dr. Barbot?
I agree. We need to create systems that prioritize collecting race and ethnicity. And, what I always say is there's a difference between talking about promoting equity and comparing it to actually hardwiring it into the way in which we do our work. So, for example, we collect information, demographic information, when we go get vaccines. What's your date of birth? What's your address? It's easy enough to add what's your race and ethnicity. And as a country, we don't do a good job at collecting this information. Sometimes people say, well, we haven't gotten enough guidance from the federal government about how to standardize it. And they hide behind that. I would say really they hide behind that to say, well, we don't want to make a mistake. The issue is, how do we work together to ensure that, yes, there are standardized ways of collecting race and ethnicity data, but beyond that, holding our systems accountable for collecting that data. And the fact that to date, we only have 23 states that are reporting on race and ethnicity of the people that have been vaccinated is unacceptable. That shows that in spite of talking about the need for health equity, we're not taking a holistic view of how is it that we build it into our workflow systems to just make it a part of our everyday work.
Right. And I would just add to going back to the people who we are serving. There is often reluctance to put race, ethnicity data if you're a patient. People don't trust our systems. They wonder how that information is going to be used. And so I think all of this is intertwined with how do we build trust so that people, and particularly people in communities where there is a historical reason for mistrust of medical systems, Black and Brown people. So clearly, all of this is related to how do we build that kind of trust so that people are willing to share their information, so that they believe that it will be used in a way that is for their benefit and not for ways that will be further harm or stigmatizing. So I think it's part of a holistic approach to how do we make sure that the experience that people are getting, the experiences are positive experiences, so that people are willing to share that information as well. Because there, frankly, oftentimes there is reluctance and concern about how the data will be used.
No, so that's incredibly important. You talked a lot about, both of you talked a lot about trust, right? Trusting the data, trying to have trust and faith in government amid the pandemic, amid a transition of a presidential administration. So, like we've talked about, there's his historical distrust there. How do you make the case to a person of color right now to go get the vaccine? Like, how are you making that case to anyone of color right now? Dr. Barbot, we'll start with you.
There are two ways. One is from, the public health authority point of view. It's incumbent on us to put together the information, to translate it, and to get it out into communities. The second, and I think in this particular scenario, probably the more important one, is for us to work through trusted messengers. And it is, and I was thinking as you laid it out, it's like, yeah, it's going to be really hard to get people to trust government, and especially in this time. And that's why it's important to work with community-based organizations that have long-standing, trusting relationships with the people that they serve, so that the messages that are crafted by public health authorities, by the scientists, are then translated in a way that mesh with people's everyday reality, that take into account the complexities of the mistrust, what goes into that feeling of mistrust. The other thing I will say is that there was a recent Kaiser Family Foundation survey that really highlighted the point that the main factor that will make it more likely for someone to accept vaccination is knowing another person who's been vaccinated. And in the Black and Brown community, there's roughly a third of people that have been vaccinated to date across the country. And so we need more Black and Brown people, be they doctors, be they your elderly neighbor, to be vaccinated and to be talking about it with their trusted groups, to really tease out the myth and the inconsistencies and share the data and share the truth about the importance of getting vaccinated.
Dr. Gayle?
Yeah, I would add, totally agree. And I think that there's one other element that I wish we would do, and I believe we will, which is to have a national campaign. We do need to have something that level sets for the whole nation, the facts, the figures, the risk, and everything, so that we have something that is consistent across the whole country. And that's, we've lacked that kind of national consistency from the very beginning. And so, having a communication campaign that kind of, level sets for everybody, I think is key. And then working at the local level, making sure there are trusted messengers, people that look like you and me, so that we feel like there are people who we can relate to. I think one of the best advertisements for this vaccine is Dr. Corbett at NIH, the young African-American woman who was part of, the team that led to, the Moderna vaccine. When people see her and see this, young African-American scientist who can vouch for this vaccine, that speaks volumes. And I think we need to have more people see people who look like them to trust this and believe that, what the government, what the scientists are telling them is actually okay.
Got it. When you're thinking about the COVID-19 vaccines and everything, there's a history there, right? Where people are worried about vaccine immunizations in general, right? And the potential effects of them. There's that historical distrust that we've been talking about. But, at what point do you feel as if the public health community can take accountability for some of this long time distrust? Like, at what point can they just say, we have messed up with how we've communicated in the past. This is how we're going to move forward. When does that start to happen?
Trust gets built on a daily basis. You can't say we built the trust and now let's just move forward. Trust is in every interaction that a person has with the healthcare system, with whatever system. But, so it is that interaction every day, how people experience it, that, continues to build the trust. And just like any relationship where every day you have to have relationship maintenance, if you will, it's incumbent upon us to make sure that we're acting in a trustworthy way in all of our interactions. And that's what will build the trust long term, not some one-off effort, but how we behave every day, which means that we need to have a health workforce that is reflective of our populations, that understands cultural differences, that we really continue to build that kind of ability to reach out, be empathetic. All of those things are critical if we want to build trust and maintain trust.
Dr. Barbot?
Yeah, I'll build on what Helene laid out because I agree with what she's pointed out. The other thing, Marissa, I will say is that vaccine hesitancy is one of the top 10 global threats to public health. And it's something that has been building over the last several years. 2 years ago, when I was health commissioner here in New York City, we had the largest measles outbreak in over 30 years. And, the root cause of that was vaccine hesitancy. And it's not just vaccine hesitancy here in the United States, it's globally. And so I think part of what public health and the healthcare delivery system have sort of fallen victim to is taking our past successes for granted, right? The fact that, we have virtually eradicated polio, that up until recently we had just about, eradicated measles and the advances with chickenpox, et cetera, et cetera, et cetera. We've taken it for granted that that's just the way that things are, and that everyday Americans will have the same kind of mindset that we in the public health or healthcare delivery system have. And that's just false. Obviously, there are people out there that are invested in having people mistrust vaccines. And so it's incumbent for there to be resources allocated for ongoing vaccine education. Because, 2 years ago, it was measles. Today, it's COVID vaccine. Next year, who knows what the condition will be that we will need people to get vaccinated for. And so it's something that we can't take for granted any longer because it's costing us lives every day.
And if I could add to that, I think vaccines are probably our best weapon, if you will, against particularly viral diseases. But it's a preventive measure. And, as people see less and less vaccine preventable diseases, like, most people have never seen a case of measles, for instance, it's easy to take for granted that we don't need these. And, prevention is difficult. You're telling people who are basically well to take something and potentially have some risk associated for a disease that they don't know whether or not they will get. It's very different than if you are sick and you take a medicine because you're already sick, you want to get well. And I think part of the story of vaccines is really helping us understand the importance of prevention overall so that we are willing and receptive to more vaccines as they become available and as we need them, because we know that this is not the last pandemic that we will see.
On that note, as we have a few minutes left, this is a big, lofty question, so you'll just roll with me on this. Can we eradicate health disparities in our lifetime? Is it possible? Whoever wants to start.
Well, yes, I believe that with the will, we have the tools to do it, but we have to recognize that it is not there's no magic bullet. There is no one pill that one can take to eradicate health disparities. As we have both mentioned, the social determinants of health probably definitely account for more of the disparities. So to be able to improve health, we've got to get out of the health box, if you will. We have to look at an integrated approach to housing, to education, to income, to public safety, all of those, to safe and nutritious food. All of those are part of eliminating health disparities. And if we see it as a health problem only, we won't be able to eradicate health disparities. But just like I believe it's possible to end wealth inequality, I think we can also end health inequality.
Dr. Barbot?
I think it's absolutely possible to end health inequities in our lifetime. We need leaders that are courageous enough to think outside of silos and to have the courage to redirect resources where they're needed, and to stand up to political pressure. I think in terms of the mindset that we'll need, just to use a really brief example of what we saw during the early parts of COVID that will play out till the end of COVID and then the rebuild. And it's the fact of early childhood centers. They closed early on when, we had to go into a shutdown mode. As we were reopening, we surveyed to see what they needed in order to reopen. And what we looked at was, what are those data voids? Where were we not getting the information that we thought we would need? In Black and Brown communities, these centers were not reopening because they're small businesses typically run by women of color. And so when we think about eliminating racial inequities and thinking about holistically health and economic prosperity, we need to think about the continuum that supports Black and Brown small businesses, that thinks about what are the components that will help people get back into the workforce. And this same example of early childhood centers, understanding how is it that we leverage these small businesses to set young children up for success by having access to high quality educational experiences, because that has been demonstrated to really have one of the greatest impacts in eliminating racial inequities moving forward.
Great. Well, on that note, thank you both again, Dr. Barbot, Dr. Gayle. Really just so appreciative of all the work you're both doing as it relates to COVID-19. And thank you everyone at home for watching. We appreciate you.
Thank you.
Thank you.